And that applies really to any sort of first aid at all, but particularly in resuscitation. And there's three things really that we need to consider, particularly here at Chailey. The first one, if you're doing the breathing for somebody, then they will always regurgitate their stomach contents. Now, it isn't very pleasant, but there have been cases of things like TB, severe acute respiratory syndrome, even things like Legionnaire's disease passed on from the casualty to the rescuer through those horrible stomach contents. Now, I say here at Chailey because you actually have, amongst the kit that you carry, these things. I say kit that you carry, so these are dotted around the canvas. So you've got these one-way filtered pocket masks around the place. Off duty, you have a different duty of care. So if you haven't got protection, the expectation is that you wouldn't do the breathing for somebody unless you choose to. You know, you have a different obligation. Here at work, you have a duty of care. So you'd be expected to know where these are and to be prepared to use them. The beauty of these is that you can safely get some air into somebody. The stomach contents will still come back eventually, but they will trickle out of the sides. You won't, if you like, the cross-infection risk is actually minimised then. So, as I say, familiarise yourself with where they are and be prepared to use them. The second danger, and this really applies to Chailey in one particular sense completely, is moving and handling. When you dial 999, the call handlers have a script to follow, and partway down the script, it will tell you to get that person to the floor. Now, I mentioned at Chailey, you've got people in moulded wheelchairs, some of them have got twisted spines and torsos, you know, all different shapes and sizes. Their wheelchairs are actually moulded to fit them. The best place to do chest compressions if you're having to do CPR on somebody is with them in that moulded wheelchair because it's supportive. We put that to the test a few weeks ago. We had somebody we were risk assessing and also doing a sort of mini first aid course for the carers, 10 of them. And we actually set up mannequins in a spare wheelchair. It was exactly the same as the one that he was using. And he was quite a big guy. He'd been, I think he'd been a Marine, and he'd had an injury, a brain injury. And it had rendered him paralysed, certainly from the waist down. And one of the things he had was an impaired swallow reflex, so choking was something that he was going to suffer from. And we did this risk assessment with him in the wheelchair, and it taught us lots. The first thing it did teach us was that the wheelchair itself wasn't very stable. And some of them are stable and some of them are not, because we've done several similar exercises, but this one wasn't. And if you were trying to do chest compressions with the guy in the chair, the whole chair was going to tip up backwards. And that really wasn't very satisfactory. And choking was even worse. It really would have knocked him completely out of the chair and onto the floor. What we actually did in that situation, we actually backed his chair into the wall, put the brakes on, and then the wall was supporting the chair. So you could do pretty much whatever you needed to. And it taught us a valuable lesson actually in that situation. But every situation is different. Do not put your backs at risk is the message. If somebody hasn't got a twisted torso and you can easily get them out of the chair, that is fine. That isn't a problem. You can safely get them to the floor. And if there's several of you, a couple each side, obviously you undo all the buckles and clips and goodness knows what the people have. But if you've got somebody dead in bed, there's no safe way for you, one person, to get another to the floor. Again, if there's several of you, you might manage to do that, but don't put your backs at risk.
And spinal vests?
The spinal vests would have to be undone, wouldn't they have to be removed? Yes, as well as say you'd have to take all the clips and buckles off. All make sense? Yes. Fantastic. The next thing's response. We've actually shown you this already with the recovery position. So shake and shout, call to them, give them some sort of a command. As Lynn said, the last thing to go is to hear, and so they might be able to respond. So, hello, can you hear me? Open your eyes. It doesn't matter what you say, just something to get some response from them. You would do that shake and shout for anybody, toddler age upwards. When we get to children, I'll show you the difference there. You need to establish that they're not actually breathing, not taking a normal breath. So have a look in the mouth first of all, making sure they're not sucking a ready tablet or a peppermint. Because often if people think they've got indigestion, it turns into a heart problem, or is a heart problem, they've mistaken it. They can be sucking a ready tablet or something like that. You really don't want to open the airway, it's going to go down and make matters worse. So it doesn't turn on the mannequin. You can turn the head to the side and just fish anything out that shouldn't be there. Then you're going to open that airway, as we showed you this morning with the recovery position. Open the airway up so you give them the ability to breathe. You're then going to do a quick 10-second look, listen and feel breathing check, but if you suspect they're not breathing, you wouldn't worry about the pulse check. If they are breathing, then a pulse check is useful, but it certainly isn't if you think they're not breathing. So 10-second check, putting your cheek to their mouth, looking along the chest, feeling with a hand if you need to, but literally no more than 10 seconds. And in that 10 seconds, you need to have heard a normal inhale breath. And when the body's coming to the end of life, the whole body relaxes, everything just shuts down. And that can include the diaphragm, which can shoot up and knock the air out of the upper body. And it comes out like an agonal breath. It's what they call an agonal breath. And it's a sigh, or a long exhalation. And it's just that way. It needs to come in this way. It needs to be an inhale breath in that 10 seconds to know that they're actually breathing. And the other quite common thing, not in every case, but quite often, when the body, well, it's actually when the brain is suddenly deprived of oxygen, the body can go into a tonic heart spasm, very similar to an epileptic seizure. It's very short-acting, literally just a few seconds, but that's usually a giveaway sign that they have actually run out of air and they're not breathing. Now, when somebody is not breathing and we've established that they're, we need to actually perform CPR with an adult, the first thing we're going to do is chest compressions. So we get them as flat as possible. I'm going to put this on the chair, and what you're aiming to do is to press that chest wall down a third of its natural depth. So you're talking 5 to 6 centimetres on your average size adult, 4 to 5 on a child, 3 to 4 on a baby. Again, it depends on the size of them. You're using your upper body, so keeping your arms straight, right in the centre of the breastbone, the lower part of the rib cage, with your hands in line with the nipples, where they're designed to be, obviously. You're going to achieve, or you're going to try and achieve, 100 beats a minute. On a good day, if I perform 100, I'll get 80 good ones. So I need to be a bit faster than that. I'm thinking sort of 120 a minute to try to get 100 good ones. That's 2 per second. So it's quite a fast speed. And I'm going to do 30 of those before I do 2 more breaths. So on the mannequin, I'm making it click. And that tells me that I'm probably going to break ribs. They reckon 70% of adults, you are going to break ribs. The thing is, if your hands are in the right place, they will go right in the middle or right on the edges where they won't pierce anything vital. If they survive, they're going to be very sore for several months. Make no bones about that, they really will be quite, they won't be able to laugh or cough, it's going to hurt them like that. But they will get over that, they will recover. If they don't survive, it doesn't matter. It really doesn't. You're not making them any worse than they already were, because at this stage they're clinically dead. Does that all make sense? So you're going to do 30 at that sort of speed and that sort of depth. So 28, 29, 30. If I'm on my own, I've got to do the breathing myself. What you're doing with these is you're literally holding them all the way around like that, moulding it into the face and making sure the airway is open. So 1 breath, 2 breaths. I'm taking around about a second per breath, about 5 seconds to do the 2. And then I'm going straight back in again. If somebody else is with you,
Can I help you?
will you do the breathing?
I will do the breathing.
Okay, so 28, 29, 30.
So I'm now doing 1 breath, 2 breaths.
Right, I'm getting really tired.
Getting
So,
tired?
will you come in from my left?
From your left.
Okay, come in on 5.
On 5.
So 5, 4, 3, 2, 1.
And I will take over. And it is important to swap because tell them where you want them to come in from. You will get tired. And what you do get is this Laurel and Hardy act when you're trying to squeeze past each other. So, give clear instructions, come in from my right or my left or opposite on 3 or 5. Had I turned up with a defibrillator, that would take priority. And if it is an adult and you are on your own, get that 999 call out straight away before you start your CPR.
All makes sense. Any questions so far? There is a subtle difference. A subtle difference if you encounter somebody who's pregnant. It's usually a lady. No, seriously. Not if you encounter a pregnant lady in cardiac arrest, it usually happens, if it's going to happen at all, in the maternity unit setting. But you just never know what you're going to come across. And we have had one in the GP surgery over the last year. So you need to know what to do. There's a subtle difference. All of us have got a major blood vessel. It's called the inferior vena cava, but that doesn't really matter what it's called. It comes out the back of the heart, down and around, underneath the uterus, comes back up on the other side, but on the right-hand side, it's close enough to the uterus when there's a heavy baby, there's an obvious bit of weight there. The weight of the baby starts to squash down on that blood vessel, and it restricts the blood flow back to the brain. So there is a way of dealing with this, but unfortunately, if you're squeezing a circulation around here, if something's stopping it there with the lady flat on her back, which is what would happen, then it's like turning the garden hose on and putting your foot on it. You're going to build up the pressure, and it won't be very effective. There are two ways of dealing with it. If you're on your own with that person, the only thing you can do is to lean the lady towards her left-hand side. So if you think lean left, that's quite a good way of remembering it, but always towards her left, towards her heart. Then this year's saying 30 degrees, last year they were saying 20. Quite how you measure it, I'm not quite sure. It's, it's not exact science. But I think, if you think of that as being 90 degrees, you'd halve that and go down a bit. And that's about 30 degrees. The problem then, you're doing backwards chest compressions. Ever so hard to do. I've tried it and it really isn't very easy to do, but it's all you can do if you're on your own with that person. So, either prop her up on your knees if she's on the floor, or get something bulky like shopping bags, rucksacks, pillows, cushions, whatever you can, to actually pop onto her right-hand side to tilt her over. However, if there's more than one of you, somebody can apply a lateral uterine displacement. And all that means is you shove the bump over a bit. So she's flat on her back, and you're either pushing and holding, or if she's round that way round, you're literally pulling it like that and holding it. Somebody else is pumping the chest, and that's the way we deal with that. Again, does that all make sense?
Yeah, yes.
Any questions so far? Children and babies, very scary things. Now the cause with children and babies tends to be respiratory. It tends to be cardiac with the adults. I know here at Chaley you have obviously children with different situations, but presumably you would know those ones that had particular conditions that might mean they would have a cardiac problem. But generally speaking, it's the respiratory ones. Croup, asthma, choking, obviously. With tiny babies, just a plug of mucus will stop them breathing, because until they develop the cough reflex, they just sort of, they haven't really got that sort of strong reflex that would cough something clear, and they just give up and stop breathing. So it's not a very good thing at all. Danger's exactly the same. They will still regurgitate stomach contents, potentially with the bigger children, and certainly some of the ones in the wheelchairs. You've got the moving and handling problem as well. The response, I mentioned the babies are different. You wouldn't do the shake and shout because of that head and neck. So support the head and neck and call to them, that's fine. Hello baby, can you hear me? Open your eyes. They might respond. But again, if you're not sure, try and get a little bit of a painful sort of reflex from them. Something painful that they will pull away from. Sole of the foot is the best one of all if you can get to it, but then you might not be able to. But if you can, scratch with a fingernail or flick, and the reflex would be to pull away like that. If you couldn't get to that bit, again, the best one of all, the base of the neck there. That is really painful. I know that because somebody did that on me the other day and it hurts.
It's fun, it's fun.
So pinch the base of the neck or the shoulder blade, earlobe, and they will pull away if there's any response to be had. If they're not breathing, they're not going to respond at all. And they will change colour very quickly. But if you're not sure, and this would apply to any age group, there is a cheat you can use. If you pull down the lower membrane of the eyelid, so just pull down the lower eyelid, and the mucous membrane at the bottom of it would be a pink, sort of healthy pinky red colour. A little bit paler if they're anemic, it very, very quickly darkens to a pink purple. And again, that applies to any complexion. An Afro-Caribbean complexion, it would be exactly the same, so that wouldn't be any different. So that's just a little cheat you can use if you're not sure whether somebody's breathing or not. You do your quick 10-second look, listen, feel, breathing check. Be very thorough though with toddlers to check the mouth before you do open the mouth. Because as you probably know, they'll crawl around the floor and they'll find anything that's going and they'll stick it usually up their nose, but sometimes in the mouth. And they'll hide it away in the cheek space. So have a good look. If there is anything there, turn the head to the side and fish it out. Open up the airway. Don't over-exaggerate with the baby. You can cut the airway off by going too far back. So literally, just neutralise, just nose to the ceiling is what they say. But the other fundamental difference kicks in at this point, and that is the relative size of them. If you can imagine your average adult in the region of a teacupful of air in each lung, so they're good for 2 or 3 minutes, there's quite a lot of oxygen in the system, the blood is oxygenated, etc. You've got a tiny capacity with the babies, around about an egg cupful by comparison. And by the time you notice they've changed colour, they've got limp and floppy, they will have already run out of air. So it's really important to try and get some air into them before you do anything else. And if you're on your own with that child, do at least a minute's worth of CPR before you make that emergency call. They haven't got the luxury of 2 minutes that it's got to take you to conclude that call before they actually, they've got to take damage. So if you've got one of these, which is an adult-sized pocket mask, these are actually good for anybody over 6 months. Under 6 months, you can see you're going to lose quite a lot of the air out of the top of that. You could persuade it over the whole face, but it's a bit tight across the temples. Turn that upside down, so it's the pointy bit's now going over the chin. You can actually then persuade that over the whole face. And it's quite a snug fit over the top of the forehead there. You can persuade that over the whole face, get 5 initial rescue breaths in, very much more gentle, just enough to see the chest rise and fall. That's all you're looking for. 5 rescue breaths, spread that around with chest compressions. You'd use 2 hands on your bigger child, just the 1 hand on your toddlers, not an exact size, depends how big your hands are, how big the child is, but up to probably 4 or 5, you just use 1 hand, 2 fingers only on your tiny babies. Centre the breastbone in exactly the same spot and the same speed. Doesn't click on the baby, which also tells me something else. And that means that you're not going to break ribs. Because certainly with the babies, it hasn't formed into a rib cage properly. It's just a nice yellow cartilage until they're around about a year old. And generally speaking, children are much more supple. I know there's going to be exceptions here at Cheney, but again, you would probably know who they were, and that again would heal up if, the worst thing is that they're not breathing, and at this stage, they're clinically dead. So you've got to try and improve that if you can. The other thing here at Cheney that you would need to know, and this actually, it's slightly contradicted in the books, because the books are designed for members of the public. If you halve the ratio of compressions to breaths, it just gives them twice as much oxygenation, twice as much top up. So 5 initial breaths, then 15 chest compressions before you do 2 more breaths. And for children under 12, that is the optimum sort of ratio, if you like. As I say, the books actually teach the adult ratio, which is 30 to 2, but we credit them with a bit of intelligence.